Hello, everyone. Welcome to the Dr. Sophia ObGyn Podcast. I'm an ObGyn practicing for over 15 years in my native New York City, and I love to help women learn about their bodies, empower them, and embrace themselves. On this podcast, we talk openly and with heart about all things affecting women, from pregnancy, menopause, periods, sexual health, fertility, and so much more. Disclaimer: this is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Hello, everyone, and welcome to the Dr. Sophia ObGyn Podcast. I am so excited about today's episode. I can't contain it because we have a special guest, which everybody here knows how much we love having guests. And of course, I'm here with my co-host and very good friend, Touseef Mirza.
Hello, everybody.
We have such a treat for you all today. We have with us Dr. Melvin Thorton,
AKA Dr.T, which I'm so happy that he's given us the okay to call him that way because that's so cool.
Yes, 100%.
So we have Dr. T, and Dr. T is a reproductive endocrinologist, better known as the fertility doctor. And what's really cool about him, he's been doing this for 30 years, though of course he doesn't look like it, helping to build families. He's a medical director of the Global Fertility and Genetics practice here in New York City. And one of the things that's extra special about Dr. Thornton is that he is one of the world's leading experts in egg donation and surrogacy. And he is among the very, very few Black male reproductive specialists who are dealing with the experience of the third party in the fertility world. And last but not least, he is an obstetrics and gynecologist and boarded also in reproductive medicine. So without further ado, Dr. Thornton, or Dr. T, as we like to call you.
Yeah, please call me Dr. T. It's a pleasure. The pleasure's all mine. I love these type of forums because it gives me a chance to tell everybody about what I do, because everyone is so afraid of fertility. They hear the word fertility and they kind of shy away. They don't want to talk about it. It's always in the closet. So today we get to open the closet and expose everything and talk about everything and make everyone feel comfortable about their own fertility.
It's true. When you really think about it, when we think about fertility, we have a negative connotation, or like if we talk about it, that something is wrong, or else we shouldn't almost be talking about it in a way, right? It's not normal conversation.
It's a good point, because fertility becomes a blame game. Whose fault is it? Is it the woman's fault? Is the male's fault? But the women are the ones who take all of the blame, because we think fertility issues are always related only to the women. But in fact, about half the couples have issues because of sperm.
Wow.
Yeah. And that's astounding, because I see a lot of patients who will come to me. They've had their workup done, the female. They've actually taken medication to make sure they're ovulating. Some of them have actually had surgery. And I'll say, well, where's the sperm analysis? They say, oh, we've never done a sperm analysis. And we do a sperm test. And all along, the issue was the male. I try to teach the residents, when I see residents, and say, you evaluate both the male and the female at the same time, because it's equal number. It takes two to make a baby, it takes two to do a workup. So we have to evaluate the male at the same time we evaluate the female. And the thing about guys, I always tell people that guys, we're broken. Now, this is why we're broken. Because we know that the female chromosomes is 46XX, okay? The male is 46XY.
Mm-hmm.
We're missing a little tiny piece on the X chromosome that we don't, for understanding and all these different things. So when you talk to a guy and you feel like he's not getting anywhere, like we're not paying attention, we just can't help ourselves because we don't have that little piece of the chromosome. So always remember that, okay?
It's the chromosome fault. Is that what you're saying?
It is, it is. We got to blame it on
It's on
something.
that Y. Okay, I love it. I will definitely be using that.
Well, we had guys come in and guys believe that the sperm is related to their manhood. So if their sperm count is low, that means their manhood is not as good as they thought it was. So they're afraid to go and get their sperm tested because they don't want to find out that it's them that's the issue, which makes them less of a man, which it doesn't.
Yeah.
It's just sperm. Sperm is sperm.
Sperm is sperm. Can we write that on a T-shirt? Because it's true. It has nothing to do with the character of a human being.
We just don't understand that. And the other thing that's important for everybody to understand is that when you have intercourse and you have the ejaculate or the semen that comes out, that doesn't mean that you have sperm. Okay, sperm is microscopically inside that semen. So a lot of people say, well, I'm good because I got a lot of the ejaculate. And I say, well, that just means you have a lot of volume of the semen. We don't know if there's any sperm in there.
Right, of course.
So there's two levels in terms of whether or not there is sperm, and number two, the quality of that sperm.
Yeah, that's correct. And when somebody comes in to do a semen analysis, we look to see how many sperm they have, how are they moving, because in order to get to the egg, they have to swim to the egg, so we make sure they have good swimmers. And then the shape. And the shape of the sperm, only the normal shaped sperm are able to fertilize the egg. So those are the three parameters that we really assess. And the sad thing about it is that realistically, a semen analysis takes for a guy maybe 2 minutes at the most, and about 1 minute 30 seconds is filling out the paperwork. Okay. But it's so hard. It's so hard to get the guys to come in and give a specimen. They give so many excuses. Well, I worked late yesterday, so I can't do it today. I had a fever last week. So it's just craziness, and the women have been through, women have gone through an x-ray test to check their tubes, which is not the most comfortable test in the world. They've had multiple ultrasounds. Some of them even had surgery for fibroids and things of that nature. And I tell the guys, you give me 2 minutes of your life to make sure that your sperm is okay.
Yeah, agreed. Before we go on, Dr. T, I do want to ask you a couple of just personal questions. How did you decide that this was what you wanted to do? How did you come to be in the fertility world?
I have to go all the way back. 2 events happened in my life. I was an only child for a long time. And then when I was 12, my mom had my brother. And I thought that was really fascinating, just to see a baby and everything like that. And then she had my sister, and I said, well, more fascination. So then people said, oh, you should be a pediatrician. And I thought about that for many years, being a pediatrician. But then when I went to medical school, I said, you know what? I really like surgery. I really want to be a surgeon. And back in the day, the surgeons were complete jerks. They would throw knives, they would throw instruments, they cursed. I said, that's not my personality. I don't want to be a surgeon.
Right.
Then I did my OBGYN rotation. And the first part of OBGYN is I did GYN. I said, oh my God, there's surgery. This is like really cool. And then one day I was on call, and the OB attendant said, can you help me with a delivery? And as a medical student, no one ever, asked you to help, right? And so I said, great. And he let me help deliver the baby, which is like really, really cool. But then the coolest thing happened after that is that the nurse said, can you do me a favor? Can you hold the baby while I go do something? And I held that baby and I said, wow, this is life. This baby started a full lifetime. And I was a part of it at the beginning. And I realized that this is what I wanted to do. So when I went into OBGYN residency, I realized that a lot of women who couldn't have that hope, they didn't have that feeling of having children. And I said, you know what? I really want to help them have children. So I went into reproductive medicine just to help these women experience the joy of having a family.
Yeah, wow.
So long story, but that's how I got here. And God has a pathway for you, and he opens doors and shows you this is the door you need to go through. Sometimes I go through the wrong door, but eventually I got to the door that he wanted me to go through.
Yeah, that's a great story. I totally can relate, because in terms of my own doctor or wanting to become a doctor experience, it was first started by my uncle, who was a pediatrician at the age of 11. So that's a really cool connection there. One of the things that I think, in terms of, especially in the Black community, I feel like we always think, well, my mom had 6 kids and my aunt and my grandmother had 4 kids. There's no reason why I should have any problems. I could try, when I'm 40, because that's the new thing I'm getting now, is everybody kind of waiting to have children. So, what are some of the things that you see or that you're seeing a little bit more now in terms of some of the women of color potentially who come to see you, or just all women really in general?
I would say that one of the biggest factors right now is finding the perfect guy.
Mm.
The most common thing that I see is, oh, I haven't found the right person yet. It's hard to find a guy, particularly in New York, is what they say. And because of that, they're delaying. It goes back to the fantasy. You gotta have the perfect husband. You gotta have the perfect marriage. You gotta get the house with the picket fence, and then you put children in there. And I try to express upon that. By the time you get to where you want to get to, you're 45, 46, and then you're a bit too old to have children. Never too old to be have a productive life and everything like that. But fertility, a lot of women don't know this, but fertility starts to decline at age 30. And so the average age of the patient that I see in my
Yeah.
practice is probably about 41, 42. And when I get like a woman that comes in who's 28, I'm shocked. I said, she must be in the wrong office. Maybe she's looking for the office upstairs or something like that. But it's just difficult. And having 3 girls makes it hard for me because as a father, I want them to get that education. I want them to find the guy that makes them happy and do their career and then think about having children. But since I became a fertility specialist, those things have changed. I'm like, okay, if you have a baby, that's great, okay? Because I don't want you to be sitting in front of another doctor's in a doctor's office, with the pain of not being able to get pregnant. And I would say the worst thing to tell a woman is that her fertility is gone. And I just had a recent, cancer journey, so I can share this with you. But telling, when you find out you have cancer, the first thing you say is, I'm going to beat it. What do I have to do to beat it? That's the first thing we say. Telling a woman that her fertility is gone, that's not the first thing they say. They feel lost. They feel there's no hope. And they start blaming themselves. Why did I do this? Why did I wait so long? Why did I take that job? I shouldn't have taken that job. I should have gone ahead. And then there's a lot of women who do get pregnant at a young age and decide it's not the right time. And they reflect upon that and start blaming themselves for that. And so there's a lot of emotion. Instead of saying, okay, what can I do to have a baby? Because there's other options to have children other than, natural pregnancies, other options, adoption and, egg donation, things of that nature. But they feel so defeated and they internalize it. And it takes a long time. And I think where we're lacking as a specialty is that we don't have a lot of fertility counseling and coaching in our field. We need a really, really good fertility therapist, somebody that we can refer to. And the reason why I say that is because women will talk about everything with each other, to their girlfriends. They'll talk about A through Z. There's 2 things they don't talk about. One is fertility, and the second is miscarriages. And they feel all alone when they're not able to get pregnant or they had a miscarriage. They feel all alone, like this is the only person it's ever happened to. So when you refer to somebody for counseling or therapy, they usually just go to a therapist that doesn't really specialize in fertility. And so now they're dealing with all the emotions of everything from their background, everything like that, instead of dealing with the emotions of, I'm having difficulty getting pregnant. What does that mean? What does my future hold? I always tell people it's a bridge. And my job is to kind of get you across that bridge. So either I want to have a family, and over here is that you either have a family the natural way or maybe through other ways like egg donation, surrogacy, or adoption. And my job is to get you across that bridge to the right place for you. And there are a lot of women who are stuck. They're stuck in the middle because emotionally they can't move forward. And I think a fertility coach can help them through that. Just somebody you can talk to say, hey, I had a hard day at work today, and this crazy doctor wants me to take fertility drugs tonight. I don't know if I can do it. And they're not going to call me to say that. They're not going to call their friends, so they sit and struggle with it. Like, you're faced with, I got this injection. Can I do it? I don't know if I can do it. And, there's so many women. I'm just so, I don't want to say proud, but I'm just amazed at how women do it. I mean, they go to work, they do all the things they have to do. They do their fertility drugs. They go through the injections every night if they're doing IVF. And I always say, if guys have to do this to have children, the wife would say, hey, honey, how'd the doctor's visit go? And he would say, yeah, we're not going to be able to have children. I'm not going to go through all that stuff. So
that dream is gone.
yeah, that dream is gone. Forget about it. Let's take a vacation. Let's go somewhere else. But it's just they're very, very strong. And sometimes when you're strong, particularly Black women, when you're strong, we're always taught as, people of color, African Americans, that, especially men, you got to be strong. You can't show your emotions. And so women that come home every day dealing with their emotions and not speaking out and talking to someone about how they feel, and stress in itself will affect fertility.
Mm-hmm.
There's some women who get so stressed out that they start skipping periods and they stop ovulating and they have difficulty conceiving just because of that. So having a fertility doula would be amazing. Something I can say, hey, talk to this person here as you go through the treatment or not go through the treatment. They can walk you through everything. That's the biggest thing I wish that we had in this field. I mean, there's some people that do it, but we need more people dedicate themselves to that. Yeah.
So I wanted to go back a little bit in terms of the basics. When should a woman come and see you? Like usually you said like women come and see me when they're like 40, 41, because now they're realizing that it's time, but they're having trouble conceiving. In general, what is your recommendation of a woman to come, almost like a routine checkup, if there's even one, when it pertains to fertility?
I would say before, the most important thing is before they see me, they should see their PCP or their OBGYN. Okay. And when somebody goes to the OBGYN, you get an examination, your heart and your lungs, you get a full check. How is your body doing? But what I'd like to see is that GYN do a special test called the anti-Maillard hormone, or AMH. And the AMH is a hormone that lets us know what number of eggs do you have. Do you have a good number of eggs or a low number of eggs? And I just think that should be part of the annual examination for a woman of reproductive age, because there are a lot of women walking around that have low egg numbers and don't know it. And by the time they wait 3 or 4 years from now to get pregnant, they're not able to get pregnant because the egg numbers are too low. So I always say it's best to see somebody else before you see me, because by the time that you're seeing me, that means that there's something wrong.
Okay. And when you say a woman of reproductive age, what does that mean for you? What is that range?
Well, I mean, technically, anytime somebody's ready to have a baby or thinking about having children, to come see me. But reproductive age is any age. I know there's age for consent and things of that nature, but people who are 21, 22 come in and have a low egg reserve because they say, I want to be an egg donor. So the first thing we do is we check their egg reserve with that AMH test. And many times it comes back low. And if they weren't coming in because they wanted to donate eggs, they would never know. They'd be walking around with a low egg reserve, not ready to have a baby. And by the time they turn 35, 36, and I'm ready to have a baby, then at that point, when they come to see me, I wouldn't be able to help them because the egg reserve is too low.
So I love the fact that you mentioned the AMH test. I love the fact that you say that they should see your OBGYN, because me as an OBGYN generalist, it's something that I speak to my patients about. It's more than just when I see a 20-year-old, it's kind of like, or someone who's in their 20s, for example, who's coming in, let's say, for birth control. The conversation also is, well, I'm glad you're coming in, you're thinking about your fertility. Do you know when and at any point would you like to be a parent? or would you like to get pregnant? And for us to help us decide, just in terms of even the contraceptive journey that they'll be on, is it one that's a short one, perhaps with a short course of things like birth control pills, versus a longer acting one, let's say with an IUD or an intrauterine device for longer periods of contraception. But it's with the understanding that at some point, do you want to have children or don't you? I think it's important to ask that question. And doing these kinds of testing on, I for sure, if I see a woman at the age of 30, usually in my practice, who's never been pregnant, I 100% ask, well, when are you thinking about having a baby? And I think we should do a baseline fertility test.
You know, there's a lot of times too where a woman will go to her gynecologist and she's not taking birth control, and it just gets overlooked. Like, okay, well, if you're not using birth control, you're sexually active, and they say yes, and say, well, I've been sexually active without birth control for 2 or 3 years. That should go off as an alarm that there's an issue because something should have happened in a young woman not using birth control who's sexually active. And if nothing happens, at least the evaluation should be started. Doesn't mean treatment has to be initiated, but the evaluation has to be started, which means that all of this should take place before they come to see me, because a lot of times by the time they come to see me, it's a bit too late. So I think the GYN, the journal, the PCP should do a lot of the work just to kind of identify women who may be at risk for fertility issues and get them a referral sooner than later. So now I'm seeing them in their early 30s, and we're making a decision not about having a baby right now if they're not ready. But now we start talking about, well, should we freeze your eggs or not for the chance of maintaining your fertility for the future?
Can you walk us through a little bit of what egg freezing is, what it's like? Does that mean that they have to do the same kind of fertility treatments as far as IVF? I think the barrier is many women think that this is going to be not just expensive, but very taxing on their bodies. If you don't mind just kind of walking us through what is egg freezing or some fertility conservation.
The biggest thing that's happened to our field is the ability to freeze eggs. And there's a procedure called vitrification, which is basically rapid freezing, right? That came about around 2012. Before 2012, egg freezing was experimental. And the reason why it's experimental is because when we froze eggs, we didn't think they were going to thaw very well. We didn't think they would lead to a baby. So only women who needed it, such as someone diagnosed with cancer, they have no other choices to preserve their fertility, we would freeze their eggs. But with the advent of vitrification, we showed that in a healthy egg, if we freeze it, that egg in the future has the same chance of being successful as a fresh egg. So that was a big revolution. And that's what, 13 years ago. That's why I love this field, because it's forever. It's changing quickly. Basically, it is taking fertility drugs. The commitment of the hormone injection is about 10 to 12 days. It's a little tiny needle underneath the skin called subcutaneous. The office visits to monitor how the eggs are growing is probably like about 3 or 4 visits. So it's about a 2-week process from the time that you start your period to the time that we're able to retrieve the eggs. And the egg retrieval, every woman loves the egg retrieval because we use IV sedation to get a medicine called propofol. And a lot of people think of propofol as a Michael Jackson drug. Well, number one, Michael Jackson wasn't monitored the way that our anesthesiologist will monitor you when you come to retrieve your eggs. But they get a nice little nap, and it takes about 15, 20 minutes, depending upon how many eggs they have, from start to finish. Recovery is maybe like about 30, 45 minutes, may have a little bit of mild cramping. But before you leave the office that day, you know how many eggs that you were able to retrieve.
Wow.
I would say the biggest drawback to egg freezing is the cost. Because, the insurance game is the worst game around, because somebody say, well, my insurance covers egg freezing. But then when you look further into it, it'll say only for medical reasons. And technically what we call social freezing, or just preserving because you want to preserve, is not a medical reason to freeze your eggs. So the insurance company say, yeah, we cover it, but only if you are diagnosed with cancer or some catastrophic events happen, you need to freeze your eggs, which is not what happens to most women. So cost is the biggest factor. I would say in New York City, you will see costs anywhere between $5,000 to up to $13,000 to freeze your eggs. The medication may run anywhere between $2,000 to $3,000. So, you're looking at about, anywhere between $8,000 to $10,000 just to freeze one cycle of eggs. And it's all about the quality of the egg, which means the age. The younger you are that you freeze, the better quality. So you don't need that many eggs. But as you get older, you're going to need more eggs. So you need more cycles going through the IVF, maybe 2 or 3 cycles to freeze enough eggs for the future. And it gets very, very expensive. And a lot of women just can't afford to do it.
These days, what is the average age of the woman that you're seeing that wants to have their eggs frozen?
Unfortunately, 38, 39.
Okay.
Yeah. And we can definitely freeze the eggs, but the big issue, and egg freezing is controversial because some people say, well, if they freeze their eggs, they have a false sense of security. In other words, they will delay getting pregnant longer because they feel like they can fall back on the frozen eggs. So that woman that comes in who's 38, 39, I always say, instead of freezing your eggs, why don't you get pregnant? And most of them are not ready to get pregnant. They don't have a partner, etc. And they don't want to use donor sperm. So now you freeze their eggs. But the big issue is that if they come back when they're, say, 43 and say, okay, now I'm ready to use those eggs that I froze, and egg freeze is not 100%. So not 100% of women will get pregnant. Now, if they don't get pregnant and they're 43, now they're trying to get pregnant with eggs that are 43 years old instead of eggs that were 38 years old.
So, Dr. T, I guess one of the things I'm definitely getting from our conversation, and it's something that I've said here on the podcast before, our fertility is really the biggest function, or the biggest factor, I should say, is our age. Would you say that that's true?
Oh, definitely. Definitely. And this is the part that I love because people don't know this. The most eggs a woman's ever had in her lifetime was when she was 5 months inside her mother's belly.
Wow.
So before she was born, she had the most eggs. That's about 5 million on average. By the time she's born, it goes down to 2 million. And as a little girl growing up, even though she's not getting her menstrual cycle, she's still losing eggs. So by the time a woman hits puberty, she starts off her reproductive years about 350,000 eggs. Now, people say, well, that's a lot of eggs, 350,000. I only use one every month. But in fact, you use about 700 eggs just to make one egg. It's a crazy attrition. And by the time a woman's 25, she's down to about 150,000 eggs. Now, back in the day, it didn't really matter because our grandparents and great-grandparents, they had children in their teenage years, which is when the eggs are the most fertile. So by the time they were 30, they were done having children. But now, by the time a woman wakes up and says she's 35, she may only have about 75, 80,000 eggs left. And that may not be enough eggs for her to actually, have a baby.
Wow.
So can you talk a little bit about that? You're saying that even if you have 80,000 eggs, you might still not get pregnant. It almost feels like the opposite. If you have 80,000 eggs, then you have 80,000 chances of getting pregnant, but that's not the situation.
I always tell people fertility is a reverse pyramid. You always have to start off with a lot to get down to a few because as humans, we're very sophisticated. It takes a lot to make a human. And so, for example, when a woman goes through an IVF cycle, say, she takes the stimulating medication, she's doing the hormones, we do the ultrasounds, and we may say she starts off that month and there may be, say, 24 resting eggs there, okay? The fertility drugs may get 20 of those eggs to grow. And the thing that's important to know is that we're not taking those eggs away. In other words, we're not depleting her egg stores any further. If a woman starts off with 24 eggs at the beginning of the month, 23 of those eggs are going to die off and only one is going to grow. So we try to keep as many of those eggs there so we can retrieve them to use them. So we're not depleting anyone's egg storage when we go through the IVF process or we freeze eggs. But if she has 24 resting eggs there, we give her the fertility drugs. There's 20 of those eggs are growing. Now, statistically, not every follicle where the egg is sitting contains an egg. So we may get 18 eggs. Now, if you get 18 eggs, we have to see how many are able to get fertilized or what's called mature. So now you may be down to 15. Okay. And then the fertilization rates, even with good, healthy sperm, may be anywhere between 60 to 80%. All right. And then of those that fertilize, 50% will become what's called a blastocyst, which is an embryo that has the potential to become a baby. And of those, depending upon a woman's age, you may see one or two that are healthy blastocysts or healthy embryos that become a baby. So out of 24 eggs, we may end up with one or two embryos that are healthy enough to lead to a baby. And then those one or two embryos that we have, if we transfer them and she's under 35, the live birth rate may be between 50 to 60%. So not everybody gets pregnant and we put an embryo back. A woman who's 38, 39, that live birth rate may be down to 30%. So what you'll see is there's a big attrition because you got to get to the best of the best. So and the whole goal is to pass on your best genetic information, which means the best egg and the best sperm. I always educate my patients that come in. I say, as humans, we are allowed to reproduce all the time. Every month we can reproduce when we're ovulating, right? And that's because we select our abnormal embryos before they implant, okay? And sometimes in women under 35, it may take 12 months before they actually get pregnant. Women over 35, it takes longer because it takes longer to find that one good embryo that can lead to a healthy baby. Whereas you look at the animal kingdom, like dogs and cats, and they'll have a litter because it's easy for them to get pregnant. But then when they deliver the litter, half the litter is abnormal. So we avoid that by selecting out abnormal embryos before they even implant. So that's why it takes us a long time to get pregnant when we're trying to conceive.
So when the women come and see you, like what you've just explained to us, it almost feels like, if you finally do get pregnant is kind of a miracle almost, right?
It is a miracle. Let me tell you, it is a miracle.
With everything that we talked about and the upside down pyramid situation. So when women come and see you, they must feel, oh my God, this is my last resource and this man is going to make magic happen and I'm finally going to be pregnant. Like, how do you talk through this? Because it must be still hard for them to fully grasp at this point. If they, like you said, if they've come and seen me at this point, there's officially a problem. So how do you start that conversation to help them understand the stakes that are in front of them?
I would say the first thing that I do is I want them to be comfortable, okay? Because I know that 95% of the information I give them, they're not hearing me, okay? Because they're sitting in front of me thinking, why am I here? I shouldn't be here. They're getting so much information from everybody else that they're very overwhelmed. So the first thing I always do is say, let's not talk about your fertility. Let's talk about you as a person. What's your goal? If this is the perfect world, you have the perfect family, how many children would you have? I always say, let's look 5 years from now. It's a beautiful sunny day and you're in Central Park. How many children do you see with you? And depending upon that answer kind of gives me an idea of what her expectations are. And if she says, I would be happy just for one, then I'm happy to hear that. But if I hear somebody say, well, I want 4 or 5 kids and they're like 38 years old, then that means, okay, I got a lot of work here to kind of make sure they understand. But we try to focus off the fertility for a little bit and then get down to maybe the root why they're not getting pregnant. And the most common thing that I see is that women don't have sex at the right time. I will say, so how do you know when to have sex when you're fertile? I don't know, we just have sex. I said, no. How do you know when you're ovulating? Well, I don't know. And that's important because when a woman ovulates, the egg can only be fertilized for 24 hours.
Wow.
After 24 hours,
It's gone.
It goes away. So you got one day out the month where you get pregnant, and everyone thinks that magic day is day 14. Now, the reason why I think it's day 14 is because women think the average person has a 28-day cycle, okay? But if you have a 30-day cycle, your magic day is day 16. So you may have sex on day 14, skip day 16, and that's the reason why you're not getting pregnant. So, the first thing I want to do is to say, hey, let's make sure you're having sex at the appropriate time. Talk about ovulation kits to make sure we know when you're ovulating. Talk about all these different things. Natural assessment of their fertility. In other words, cervical mucus monitoring, temperature monitoring to kind of get an idea of when you're actually ovulating. That's the most important thing. Then we'll start talking about, well, these are different tests that we want to do, okay? And explain why we want to do this test. And then say, we're going to do the testing, and then you're going to come back to see me to go over the results. Because I could probably know that 38, 39-year-old, let's say a 42-year-old woman walks in my office, I know the treatment I'm going to recommend is IVF. I know it because of her age. But I want her to do the testing so we can kind of review everything and say, what is your overall fertility? What's your ability to get pregnant naturally? And then say, well, this would be your ability to get pregnant with IVF. So you see that there's a big difference. So they say, wow, I never thought I had to do IVF, but IVF seems like the best choice for me.
When you say the testing, are we talking about AMH or something else?
There's 4 things that we want to do. Number 1 is her egg reserve, which is the AMH test. Number 2 is the sperm analysis. Number 3, we want to make sure that she's ovulating every month. And then number 4, we want to assess to make sure that her fallopian tubes are open so that she can get pregnant. So those are the 4 basic tests that we do. I always say there's a 5th test, and the 5th test is a good history because sometimes it could be other factors that are going on why they're not getting pregnant, like not having sex at the right time, or I would say 85% of the time, I only see the female come for the consultation. I never see the male partner. How do we know that male partner is really ready to have a child? For all the things you say about men, we're smart. And many times we know when our partner's ovulating, and we may be working late that day, or we may be really tired, I can't have sex today, because they may not be ready to have a child. So I like to see both the male and the female at the same time, just to make sure we're all on the same page. Because the worst thing is for a woman to say, I'm ready to have a baby, but for her partner to say, I'm not really ready. So now she's got to make some life-changing decisions. Is this the right person for me? What do I do at this point? So it's really, really complicated. It's a lot of therapy we do at the same time.
Yeah, I was going to say, you're like a therapist at the same time.
Yeah.
A couple therapists.
Yeah.
Yeah, I think that's probably a very big portion of the women's health world. Requires you to have a certain level of just real empathy for where they're coming from emotionally. Right, Dr. T?
Have to, because you just never know who you're going to see or why they're there. And many times they need that conversation about, is this the right guy for you? Because I'll see so many women come in and say, well, I'm ready to have a baby, but he's not ready. So I say, well, you got to be selfish. Because typically men can have children as long as they want, whereas you have a limited time. So I need you to start being selfish and think about yourself. If he's not ready to get on board, then you may have to, get him off the train and get somebody else on the train, or maybe go to a sperm bank and think about using some donor sperm to help you get to your goal. Because I don't want to see you in my office at 45 and I'm saying, I'm sorry, I can't help you have the baby, and you feel devastated.
Dr. T dropping truth bombs left and right, like one after the other. I mean, but because as women, sometimes when we want something, we really want it bad and we keep it inside and we don't talk about things like you said. And so finally, I think when they come and see somebody like you, they finally have to see things as they are. Because if they've come and seen you, you have to tell them the stakes. And so you play such an important role around that. I'm sure the women, at a certain point, they get a certain sense of clarity, and at the same time, probably a sense of devastation, because it means that, okay, I got to make decisions now. And maybe I need to stop thinking about this dream that I had, and the reality is something different.
Yeah, they really appreciate that. I've had a lot of people come back and say, even not everyone gets pregnant, and they come back and say, I didn't get pregnant, but you know what? My journey was a good journey. Because many times, if you're not able to have a baby, it's about having closure. And some of them women never get that closure, and they go through life wondering, what is this, what is that? So, our goal is to help you have a baby, but if you're not able to have a baby for whatever reason it is, we want you to get closure so you're ready to move on to your next phase in life. Maybe, like I say, that's adoption, egg donation, maybe you need a surrogate. So now you're ready to move on mentally to that next phase.
I want to switch gears from not just the ability to get pregnant, but the women who have what we call recurrent pregnancy loss, or the women who are constantly losing babies. It's really one of the things I've had to deal with just this week in my own practice. A woman who's had her sixth loss. She gets pregnant, and the pregnancy is positive. We see the embryo. She gets to about 7 weeks, and then boom, she has a miscarriage.
Those are hard. First of all, the definition of recurrent miscarriages, back in the day, it used to be 3 miscarriages, then we do an evaluation. And the reason why it used to be 3 is because her next time getting pregnant, if she has 3 miscarriages, it's about a 60% chance she'll have a baby. Okay, so because someone's had multiple miscarriages doesn't mean that they won't have children on their own. But now it's down to 2 because of the emotional toll that you go through by having losses. And the problem is that 98% of people that you evaluate for miscarriages, everything is normal. You can't find anything wrong.
It's exactly like this patient of mine.
Yeah, you just can't. And usually the reason for the miscarriage is due to the embryo itself. Most women don't realize that by 6 to 8 weeks, all the organs are formed and functioning. So if there's something that goes wrong, say the development of the heart, the body senses is not healthy, it results in a miscarriage. So there are many things that we can't test for that may be causing it. But we try to do, make sure the male and female chromosomes are normal, make sure her uterus is healthy, make sure there's no fibroids, make sure there's no thyroid issue, a lot of different things, make sure there's no blood clotting issues. And the majority of times we don't find anything wrong. It's so frustrating because the patients have lost hope. They internalize everything. They don't talk to anyone. And the first thing I say is, listen, talk to your mom, talk to your friend, anybody that has children, and ask them if they ever had a miscarriage. And probably about 2/3 of them will say yes. And now they don't feel like they're alone. It's just the only one that's happened to. But there is hope, though. I don't want women out there to think that there's no hope. There is hope. So see your gynecologist, see your reproductive specialist, get an evaluation, see if there's anything wrong. But don't be disappointed if everything is normal. And this is the funny part is that I always tell women with miscarriages or something like that, I say, if I were a cardiologist and I said all your results are really good, you'd be really excited. But as a reproductive specialist, when I say all your test results are normal, everything looks really good, women get disappointed because they want me to find something. And many times we don't find anything.
Yeah. I mean, even the treating doctor, I mean, me as the OBGYN who has a patient who walks in the office with this kind of condition, and having done all of the workup basically that you described, looking to make sure they don't have something called the thrombophilia, looking to make sure that their chromosomes are normal for both them and their partner, looking at their partner's sperm and all the things. And then everything comes back normal. And I feel just as I hate to use the word hopeless because I'm not that person. I'm like, nope, there's going to be something else we can do. We've got to keep looking, and we've got to keep trying. But it's very disheartening.
And when a woman gets pregnant, the most joyful thing is to do the home pregnancy test and see it turn positive, right? But for women who have miscarriages, it's the worst thing ever because now the agony begins. And it could be a healthy pregnancy that they're pregnant with, but they're always looking over their shoulder like, okay, when am I going to miscarry? When is it going to happen? Even through the whole pregnancy and to the point where the baby's delivering, then they finally realize that, okay, it didn't happen this time. in my field, is the hardest diagnosis to treat and take care of.
Yeah, I have another one just last week that I actually delivered who'd had 5 losses, and she told no one she was pregnant. Literally, no one knew except for her and her partner until she had that baby.
Because she didn't want to go
She
through it
just
again.
couldn't go through telling people that she was pregnant, and then, for them to like be looking for this baby 9 months later, right? And there's no baby, and then having to go through the pain of describing whatever she went through or the process. And so it wasn't until she literally was having the baby that she told like her family, like siblings or like, aunts and uncles. And so like, as you say, the thing that should be the most joyous in women who have had losses is just a constant, almost like monkey on their back.
Even women trying to get pregnant, there are triggers that people will say and not realizing they're saying anything. And women have so much pressure on them. So, when a couple has been together for more than 2 or 3 years, they never ask the guy, oh, when you guys gonna have a baby? They always ask the woman, when are you gonna have a baby? Not realizing that she may be trying to have a baby, is not able to conceive. And now she feels more pressure because the mother-in-law is asking, when are you guys gonna get pregnant? And she can't, she can't give that answer, or her mother, her friends. And I just wish people would ask that question. Let the person come out and say, hey, we just started trying to get pregnant, or hey, we're thinking about having a baby a year from now, or something like that. Because I think sometimes the worst you can say, when are you guys going to have a baby?
How do you remove that shame and realize that it's biology? It's not something that you're controlling. I mean, maybe there's certain things that you do, like if you're smoking or if you're always under stress, that does have an impact. But in the better part of things, like that's just biology. If you're getting a miscarriage, it's because the body has decided that it's not a viable embryo. It's actually protecting you. And I'm not saying this is easy. I'm just saying, like, we get so caught up in one perspective. Is like, how do we open up that conversation more?
It's education.
Mm-hmm.
It's doing this.
Yeah, doing this. If you think about it, in high school, they teach you how not to get pregnant. They don't teach you anything about your reproductive cycle when you're fertile and all these different things. No one even teaches you how to change a diaper. You have a baby, you come home, what did I do here? They don't teach you that.
That's true.
But it's all about education, particularly for women. So podcasts like this are so important. Maybe even just doing a podcast on just basic biology. When's your most fertile time? How to test if you're fertile.
We might have to bring you up a second time then. You're just coming. We'll have to do the biology of fertility now.
I would love it. I would love it because I'd rather not see her in my office and have her come to this wonderful OBGYN's office and deliver the baby and I never beat her. That makes my day. Listen, I gotta go to work, right? But I'd rather not go to work. I wish I could go to work and maybe had 2 or 3 patients on my schedule, because the majority of people are just getting pregnant on their own. Then that means that I made a big difference in the world. So until then, we gotta keep educating.
One thing that I was thinking about when both of you were talking, in the sense that when Sophia, you were saying, when a woman is in their, especially in the early 30s, you ask, do you want to start a family? I'm 53 now. I've never had any OBGYN ask me if I wanted a family. They ask me, are you sexually active? Are you pregnant? But they've never asked me.
Do you want birth control?
If I'm on birth control, but they've never asked me, do you want to start a family? Is that something that, for the women who are, and for the men, like for anybody, is for the women to actually be proactive and to tell themselves, to the OBGYN, when they're 25, 28, that I want to have a family, so they can start having that conversation if the OBGYN doesn't bring it up?
Absolutely. I would say that that's a major part of why we're here, is so that women always know that they have that level of agency that they can advocate for themselves and ask the appropriate questions to whoever their provider is, even if it is just their primary care doctor, to say, I'm thinking about having a baby. How do I go about this? Or that I want to have a baby in the future. How do I go about this? And I think we just need to keep getting the word out that women can actually advocate for themselves whenever they go in to see any provider.
I think there's this misconception, or the way that we've been brought up, and that's not just from a patient perspective, but also from a provider perspective, is if you're going to go see a provider, there's something wrong that you're trying to get fixed. But when you're actually talking about a family, that's more in terms of your life goals, right? Like, so it's not maybe something that a provider will bring up. And especially a patient's like, well, why am I bringing this up? Because there's nothing wrong. But my point is that we should, considering the critical things that can happen even just 5 years down the line, if you haven't started to talk about it when you're 30.
Yeah, it's part of preventative care. Mm-hmm. It should be anyway. What do you think, Dr. T?
It has to be brought up. The provider can do so much. Because the provider is under a lot of pressure, he or herself, to see as many patients as they can a day. So we can only do so much as providers, but we should do what we can. And I think we just have to educate the public. For good reasons and bad reasons, young women listen to people in pop culture, whoever the influencers and all these people on social media. We need somebody who's an influencer on social media to put out the right information to say, hey, no matter how old you are, do you want a baby? Go get an AMH. Let's talk about your fertility. Talk about your fertility, your next doctor's visit. Talk about your fertility. Make an appointment to see a fertility specialist. Just to kind of keep putting it out there. So one day it becomes like standard. Oh, I'm 18. Let me check my AMH to make sure I'm able to have a family in the future.
I can't agree with you more, Dr. T. It's definitely a major reason why I was so excited to have you here. What are your last words for us, for our audience? What is something that's burning that you feel like you really want to get out there that we haven't talked about?
I hear a lot of women don't go see a doctor because, if it's God's will to get pregnant, I'll get pregnant. We got to take that away because God has given us so much technology that He can always help. So see a doctor, talk to your friends, do an AMH. Just advocate for yourself. Find out your personal information, and then take that personal information and decide, what do I do with that information.
Thank you for that little nugget, because I definitely think, not to say that we can't bring in our spiritual selves into this, but we forget, if we're taking into account our faith, right, that so much has been brought about because of it, the access, the new technology, using us physicians or providers as a vessel to help women get to their ultimate goals. And so I love that you bring that point out.
It's heartbreaking for me to see that woman in her 40s and having a very poor prognosis of having a child. And then the emotions come up, and, it's always anger. And then they start blaming themselves about, it's because I did this. It's because I drank too much coffee. It's because I did this. And don't be afraid to talk. Don't be afraid to ask questions. And don't be afraid to move on, because if you got the wrong guy who's not on the same train as you are, kick him off the train and find somebody else that can get a ticket to the train that you're on.
Amen.
Amen to that. Amen to that. Oh my gosh.
And the same thing for guys too, because some guys want to have a baby and their partner doesn't want to have a baby. So if your goal is to have a family, find the right partner that can both meet your goals. A little ending bit for my fellow guys out there. About 40% of the people I see in my office now are single men who want to have a family.
What?
And it's the same, single men.
Wow.
40%. And because they can't find the right partner to have a baby with.
Wow. Okay, ladies, there are 40%
They're out
of
there.
men out there.
They're out
40%.
They're looking for you.
And let me tell you, for a guy that wants to have a baby, it is crazy expensive. There's an egg donor, there's a surrogate, right? So there are a lot of guys out there, and these guys are well off because they're working with an egg donor, they're working with a surrogate. So we got to get everybody together and say, hey, I got this guy over here. He wants to have a baby. You want to have a baby.
We need a fertility mixer happy hour thing.
There you go. A fertility matchmaker, you know.
Wow.
But yeah, believe it or not, 40% of people I see are single men.
Wow. Now, is that single men looking for women? They just can't find a partner?
That's what they tell me. Yeah, they say it's very difficult to find a partner. And they decided, they say the same thing. I'm getting too old. And for a lot of the single men I see there, and they're like mid-40s, they say, I'm getting too old. I don't want to be like 80 years old and being a young child. So they decided to have children on their own.
And this is more of a recent trend you started to see in the past few years?
Yeah, I would say in the last 5-6 years. Yeah.
Interesting.
Wow.
Well, Dr. T, I want to thank you. I mean, aside from all the information you gave us, but thank you for your humanity. And thank you for the beautiful heart in which you operate and talk with people. This was very special to me.
I really appreciate that. And I enjoyed being here. Dr. Sophia, keep doing what you're doing. Both you ladies are educating women, and that's the most important thing. And you're making my job so much easier by just having real conversations with them. And I thank you for letting me be here and be a part of this.
Yes, thank you so very much for being here with us. It was really quite enlightening. For all of our listeners, thank you for listening. Thank you for being a part of the Dr. Sophia ObGyn podcast. And always embrace your body. Embrace yourself. Bye for now.
Bye.
This is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Until next time, embrace your body, embrace yourself.